Welcome to the 2018 Connecticut Breast Health Initiative Grant Award, Sponsor Thank You, Fundraiser, and Volunteer Appreciation. We're actually introducing a new award this year, the Norma Cucillo Pink Ribbon Youth Award. Our honorees are the third generation of CTBHI volunteers. The Tucker family has been very giving of themselves for over 15 years. Connecticut Breast Health Initiative recognizes Linnea Tucker and McKenna Tucker. We'd like to give you something. CTBHI recognizes tonight a breast cancer survivor as our 2018 top pledge collector for raising $5,581 all on her own. Linda Carroll. Come on up. And these fundraisers, we're just doing the people who raised over $1,000 for us. Elaine Garrett from Microcare. New spot. Dr. Christina Stevenson from Yukon Health. Home Depot has done forever, has done the Build in the Park on race day. 1997, wow. Ron's been with us for more than 15 years. And I know you have the total in your head.
Yeah, you do.
Yeah, you do.
15 years, Connecticut USA Car Show, we have donated $210,000.
Decisions on CTBHI grants are made by the Board of Directors. But those decisions are based on the work and the advice of the Grants Committee. The charge of the Grants Committee is to make solid and substantiated recommendations to the Board for its consideration and action.
We would like to present the first grant tonight to Yukon Health. This grant will fund the genetic counseling outcomes study being undertaken by Dr. Keith Belizzi, the principal investigator of the study, along with Kate Dibble, the study's research coordinator. The purpose of their work is to identify approaches to genetic counseling and to support women and their families following the results of a positive BRCA test result. We have with us tonight Kate Dibble.
I am Dr. Belizzi's PhD student, and I act as a study coordinator working on this project. Our project specifically focuses on the patient experiences with and outcomes of genetic counseling for specific gene mutations BRCA1 and 2. Current counseling practices typically involve individual-based approaches, even though genetic breast cancer is a hereditary familial predisposition. We are interested in patient experiences for individuals versus family-based counseling approaches and outcomes, such as stress, quality of life, and perception of cancer risk. Our research hopes to inform best practice genetic counseling approaches for working with at-risk women. We are very excited and grateful for the opportunity that the Connecticut Breast Health Initiative has given us through its funding. On behalf of the entire project team, I thank you and the grant committee.
Our second grant tonight goes to Stanford Health in support of their high-risk breast cancer program. Stanford's program intended to delay or prevent the onset of breast cancer by identifying those women at high risk is under the leadership of the program's two co-directors, Dr. David Gruen and Dr. Helen Pass, along with Barbara Carr, the Director of Women and Children's Services at Stanford.
But I'm very fortunate to work with two incredibly forward-thinking physicians, such as Dr. Pass, who's the breast surgeon, and Dr. Gruen, who is a breast-only radiologist. I oversee the 4 breast centers that we have at Stanford Health, and always my two physicians are trying to come up with ways to be innovative, and really they are truly visionaries. So one of the things that they just started to do, even without funding, was to identify the risk that each woman has of her lifetime risk of developing breast cancer. So at every single mammogram, every woman at every mammogram when they come to one of our centers, she is given two risk assessments. So when we do these risk assessments, they're based on family history, personal history, whether or not a woman has had any breast biopsies, the age of her first period, whether she's had children and the age that she first had a live birth, and there are other breastfeeding, there are other factors, and they all go into this, and out comes her risk. But what does a woman do with that? What we were finding was that some of the women, when we told them what their risk factor was, and we explained that they could come see our nurse practitioner who only specializes in guiding women through this process, some of them went, some of them didn't. And we realized that people really didn't understand fully what it meant. So we wanted to be proactive and reach out to them. So we started calling each woman who had over 20% lifetime risk, and we developed a whole protocol, we ran a pilot, and about half of the women that we called came in and met with our nurse practitioner. The result of that is that they're given an active care plan. So some women will need breast MRIs, depending on why she has this elevated risk. Others need lifestyle changes. Others need just extra imaging. Whatever it is, that particular personalized care plan is put into place. So once we saw that the pilot, we had identified so many women, and so many women came in and they were actually being very proactive about their care, we realized we just couldn't let this go. We needed a program, we needed to be every woman, every mammogram, and we didn't want anyone falling through the cracks. So due to this grant, on December 15th, I just hired the breast coordinator, the high-risk coordinator, so she will be calling all these people, all the women. She will be tracking the outcomes, extremely important in any research endeavor. But I will tell you, through the pilot that we did, this abbreviated pilot, the interim care coordinator called me just about a week ago and said, we have now had our second case of breast cancer identified as a result of 2 women being called that otherwise would never have been called. And it's at a very earliest stage. So they have super fantastic odds of completely beating it. So I just want to say on behalf of Stanford Health and my colleagues that we're so grateful for this grant, and we look forward to bringing you those outcomes and letting you know what they are, and most importantly, to helping more women win in this fight against breast cancer. Thank you.
My name is Ashwin Reddy, and one of the second-year fellows at UConn. I work with Dr. Tannenbaum, and we are both doing this breast cancer research. So first of all, I want to thank the initiative for believing in us and giving this grant. And so we know that the cancer treatments have changed, and we are talking more about immune-based therapy and personalized cancer treatment. So how this project started is we was approached by a company who had a high precision circulating tumor cells. So I'll explain what is that. So we know that each cancer is different. Some cancers are early cancers, some cancers spread to other parts of the body. But we don't know exactly how this happens and who has cancers which spreads and who has cancers which is localized. One thing we know is that if any patient has circulating tumor cells, meaning the cancer cells come out from the cancer and go into the bloodstream, they have high risk of metastasis, meaning the cancer spread. So we know that from one of the tests earlier. But this company had a very high precision technology to detect those cancer cells. What this genetic makeup test is, they take each individual cancer and see what all the mutations the tumor has. And there are several panels, and right now they can do up to 500 gene panel. And what it does is, it tells us how the cancer will behave, and it can also be a potential for treatment, because there are some targeted agents. When they have certain mutations, there are drugs coming out each and every day, which can target those specific mutations. So we thought, okay, we can give some for our patients with this next generation sequencing. And we are talking with them, and that's how the grant came in. And this part of the study, which is the genetic makeup, which we are going to test on patients, will be, we are going to use the grant for this part of the study. And what this does with our other study is, we are going to compare the presence, absence, or disappearance of these circulating tumor cells with their genetic makeup and see if there's any correlation, so that we can predict that these patients are going to have circulating tumor cells and some patients who are not going to have circulating tumor cells. So this is what is our study program. And I want to thank Dr. Tannenbaum for giving me this opportunity to work with her in this study. And again, my thanks to the initiative for the grant. Thank you.
There is one integral person in this room that we have not thanked tonight formally, and I want to say thank you to Michelle Lewitt.